Dr. Tim Jochen, and today we're going to be talking about the mini lip procedure we perform in our office. And this is too high. Historically, a facelift was called a rightedectomy. And does anybody know what a righted means? It's a wrinkle. So basically, it was the surgical removal of wrinkles, and it's the absolute gold standard for rejuvenating the lower part of the face. And it has many names. It's trendy now for people to rename the procedure. Some people call it a mini lift, lifestyle lift, weekend lift, Euro lift. There are so many different names for this procedure, but they're really all the same thing. Nobody's doing anything different. They're just renaming the facelift. And so what happens as we get older is we have sagging skin, and this is from loss of collagen and elastic fibers, loss of muscle tone, and we also have some bone resorption that occurs, as well as we have some redistribution of fat in our faces. And so the indication really is to improve the jawline, get rid of that jowling that you have here, and tighten the neck here, and also just give an overall tightening of the skin. So you can see here, here's a patient, she had some jowling over here, and after the procedure, it's a lot tighter. And you can see here, again, she has a lot of tightening here. Now we call ours the mini lift, and the main reason we call it a mini lift is because, number one, we're doing it under local anesthesia. Now that decreases your risk significantly, and so that's really the big thing. And we may not be quite as aggressive with the neck tightening as you may see in a traditional full-on facelift. But you can see here, just doing the mini lift, you can see some dramatic changes in the neck and also along the jawline. She actually has her jawline back and her neck is a lot tighter. So the advantages are, as I said, we're doing this under local anesthesia. So local anesthesia or tumescent anesthesia is amazing because it lowers your risk. Dramatically lowers your risk. Basically, these people are only getting lidocaine as a medication. That means they don't have risk of aspiration or respiratory depression or things like that. And also, we have a lot lower cost because we don't have an anesthesiologist involved in this procedure. Now, we do have the certified surgical suite that we use for this procedure, so it's a safe procedure, but we also have the advantage now that we can give them conscious sedation if we like, and we have care available for that. When we're talking to people about doing mini facelifts, we want to get a history. We want to find out if they have any allergies. We want to make sure that we're not going to give them anything that could harm them. We will give them some medications. We typically will give them some antibiotics to minimize the risk of an infection. We'll give them some pain medications to minimize any discomfort that they're going to have after the procedure. And also we give them some Valium. And the Valium really helps them to relax during the procedure and helps them to get a good night's sleep before. Because a lot of people are anxious, so we give them the Valium so they don't come in all jittery because they didn't sleep the night before. We want to review over-the-counter medications, including their current list of medications, because we don't want to have anything that's going to interfere with the procedure. And things that we're mostly looking at with this procedure are going to be things that make you bleed. So Coumadin, aspirin, and we also want to know about their over-the-counter medications because a lot of over-the-counter medications have things that can make you bleed, particularly fish oil and vitamin E. We want to do a review of systems. We just want to make sure that they're healthy and able to have this procedure. If they have any serious medical problems, we don't want to do the procedure on them. We also get a physical exam on them and a clearance from their physician to make sure that they are appropriate candidates. And keep in mind, again, this is a local anesthesia procedure, so very rarely are we going to have people that are not candidates for this procedure. So pre-op, we want to make sure that people stop their blood thinners for 7 to 10 days prior to this procedure. And this includes any kind of pain medication except for one. What is that pain medication that they can take, Marisol? Vicodin, which is Tylenol based. Yeah, Tylenol. We also want them to wash with Hibiclens the night before and the morning of the procedure. And the reason we want them to do this is because it does minimize their risk of getting an infection. Stopping smoking is critical for this procedure. It's one of the few things where we really want them to stop because we're creating a flap. And a flap is just a piece of skin that's been lifted off the underlying tissue. And when you lift that off the underlying tissue, you take away some of the nutrients that feed the skin. And smoking constricts blood vessels. So when you smoke, you're constricting blood vessels which feed the skin, which could lead to necrosis of the skin or skin death. We want people to eat something before they do the procedure. This is if they're not doing, not immediately, but we don't want them to come in hungry. And the main reason for that is if they're going to take pain medications, we want them to have something in their stomach, otherwise they're going to get nauseous. And if you get nauseous and you vomit, that creates pressure, which can increase your risk of bleeding. And we also want people to arrange for somebody to stay with them overnight. We cannot allow them to be home alone after this procedure. Just because they're on pain medications, if they were to have some minor complication like bleeding, we don't want them to panic and not know what to do and have to call 911. It does not create a wow experience. So pre-op, we have pre-ops done where they're going to get their, we're going to have them talk about the regular medications that they take so that they can continue to take anything that they need to. We want them to wear loose, comfortable clothing that buttons in the front. After you do a facelift or most of the procedures we do here, they want to be able to just put on something, but to pull something over their head doesn't usually work for them. If they wear contact lenses, we want them to remove them before they have the procedure, and we want to get some labs, including how their clotting is to make sure that they can recover quickly from this procedure. We get an EKG to make sure that they have a healthy heart, and we get a clearance from their doctors to make sure that they're adequate candidates for the procedure. Now, we like to make sure that this is done 5 to 7 days before, because we don't want to be scrambling before the patient has the procedure and trying to get everything rushed. For anesthesia, what we do in our office is we do Valium to help them relax. We do 1% Lido with epinephrine along this incision line, and then we'll do tumescent anesthesia in the areas where we're going to do the procedure. So the incisions, you can see here that it's just a very small incision. We do it in the hairline, and we do it just at the base of the hairline, because if we do it here and we cut the skin, guess what happens? We just move their hairline from here to here. And hair is very precious, as we know, because we're in the hair restoration business. So we don't want to eliminate any hair. And then we go in front of the earlobe in a crease right here. We go behind the tragus of the ear, so the scar is hidden. And then we go into the natural crease here. We go behind the earlobe, so it's hidden. And then again, we go back and just in front of the hairline back here. Because again, if we have to remove skin this direction, we don't want to remove any hairs, because people want to maintain their natural hairline. And you can see here after the procedure how the scar is basically hidden. This is almost immediately after the procedure, and the scar is almost invisible. Okay, so then what we do is after we make the incision, what we want to do is we want to lift up that skin. So we do what we call undermining, and that's basically lifting up the skin from the underlying tissue. So that's what allows us to pull the skin back and tighten it, because if you don't, there'll be countertraction pulling the skin back. Okay, so then what we do is we tighten the SMAS, and this is called the muscle. People want to know if you're tightening the muscle when you do a facelift. This is what the muscle is. It's called superficial musculo-muscle aponeurotic system. And it's just a layer of tissues that covers and surrounds and attaches to the underlying deeper tissues and structures of the face and neck, including the cheek area. So this is basically the area we're talking about. It's just muscle and fibers and a little bit of fat. And so what we do is we've dissected the skin back, and what we do is we cut out a small piece of this tissue, and then we suture it back together. Now this is a slide from Dr. Nyamtu, and I appreciate him letting us use this slide. Okay, then what we do is when you remove the muscle, you're actually going to pull the skin back, so you're just removing the excess skin that's there. So there's not a lot of tension on the skin because we've just removed the muscle that's been supporting the skin. After that, we apply firm compression, and the idea here is to minimize dead space and minimize the risk that you could get a hematoma. Post-operatively, what we tell patients is we want to keep their head elevated on 2 to 3 pillows. This is important because we want to minimize the pressure and the risk of bleeding. We want them to eat soft foods, and because again, we don't want a lot of pressure or a lot of movement in the jaw area, which will increase your risk of having a hematoma. You want to take meals with pain medication so they don't get nauseous. At day 1, they come in for a dressing change. We want to see if they've had any complications, because the majority of complications do occur within the first 24 hours. And then the second day we do pressure again, and you'll see the people coming in looking like little mummies. Now there are surgeons that are more confident that they're not going to get a hematoma. I don't like to take that risk, so we do mummify our patients a little bit. We want our patients only to use pain medications provided by the office for 2 weeks after the procedure, and that's because we don't want to have them take anything that's going to thin their blood. And then no vitamins or herbs again for 2 weeks, because a lot of supplements do contain things that increase your risk of developing a hematoma. Side effects, the most serious one, of course, is going to be the hematoma, which is the collection of blood underneath the skin. The reason this is a problem is because if it were to occur, the tension that can occur from a developing hematoma can stretch out the skin and compromise the vascular supply to the tissue. And without blood supply to the tissue will die. You can get bruising. That's commonly occurring anytime you cut the skin. You can get swelling. And this typically starts at it's at its greatest at about 3 days. You can think you're not going to get any swelling, and this happens with our hair transplant people as well. They don't get it the first day. They think they're not going to get it. They call on the 3rd day, and they think, oh my God, something bad happened because swelling occurred. It's natural for it to take a couple days. You could have a allergic reaction to the medication we give you, which would be the lidocaine. You can get a headache, infection, very small risk, but even with the cleanest, sterilest technique, there's always a risk of infection. And what's that risk, May? 2.4, 2.6. You can get muscle aches because we are altering the muscles. You can get a little nerve injury. Most of those will resolve. It's a very low risk. I think it's somewhere around 0.4%. And typically, if you do get nerve injury, it's going to be the postauricular nerve, and that's a sensory nerve, so it's not hugely dangerous. You could get death, and that's usually just a reaction to the medications. Hearing loss, very unusual. Asymmetry, we always have to remind people that they're asymmetrical to start with, so there's a risk that they're going to be asymmetrical afterwards. And then the dreaded necrosis of the skin, that's if you have vascular compromise. So you can see here, nice improvement in the jawline, and again, nice improvement in the jawline, but it looks natural and fresh. And again, in the front, nice looking result. Again here, very nice looking result. Okay, so, and with this procedure, it's going to work on the lower face, but oftentimes it doesn't address the whole picture. And so we have to think about some other procedures that you use in conjunction with this. And one of the things is the CO2. This will tighten the skin and will get rid of discoloration on the skin as well. Then we have fillers, and oftentimes we've had redistribution of fats. We have some bony prominences showing up, and so we can use fillers to soften the lines. Now, some people will do implants, for example, cheek implants. I'm not a big fan of them. I don't think they look natural, and I don't think they provide a result or a look that I'm a big fan of. Sometimes they look too puffy. Sometimes you can get step off. Sometimes they slip. So I'd rather just use natural fillers to soften the contours that God gave you. We also can do Botox to relax muscles. We can do eyelid rejuvenation, removing excess skin and fat. And we can do liposuction to remove excess wattles here. So why should people choose here over other places? Well, here, you know, cosmetic surgery is an art as well as a science. And so you really want to be able to evaluate the face and make sure that they get the best procedures, and the procedures are done to make sure that it looks excellent. We're board certified dermatology, and as you all know, dermatology is the new frontier in cosmetic surgery. This is where all the action's happening right now. It's not in the surgical specialties, dermatology is a surgical specialties, but it is really going on here in dermatology. We do lots of them. I teach at USC. I'm a fellow of the American Society for Mohs Surgery. We do a lot of Mohs surgery here. We're a very busy practice for that. That's all facial surgeries, reconstructive type surgery. We have an amazing staff. We have a state-of-the-art facility, and we're a quad A certified surgical center. Quad, sorry. Okay. So any questions? Nope. Okay. Thank you, guys.